Welcome to the deep dive. Today, we're zeroing in on an organ that's really central to every meal, but maybe doesn't get much thought: the esophagus. I mean, how much do you really know about this vital tube? So our mission today basically is to take a deep dive into the source material you've shared. We want to unpack the esophagus, its world, explore how it can go wrong, sometimes in surprising ways, and understand how, well, minor issues can maybe become more serious. We're aiming to pull out the key nuggets of knowledge so you can feel pretty well informed pretty quickly about this amazing organ. Okay, let's unpack this, right? Let's start with the absolute basics. What exactly is the esophagus?
Well, think of it as this muscular highway, like you said. It's typically about 25 centimeters long.
Connecting the back of the throat, the
Pharynx, exactly, the pharynx, down to the stomach. Now, if you're measuring with an endoscope, say, from the mouth all the way down, it might look more like 30 to 40 centimeters total,
Oh.
or maybe 30, 32 centimeters, just to that lower valve, the lower sphincter.
And the structure itself, it's not just a simple tube, is it?
Oh, definitely not. It's quite layered. You've got the inner lining, the mucosa, then this layer called the submucosa.
Mm-hmm.
And what's interesting there is, unlike other bits of the gut, the esophagus doesn't really have much muscle within that submucosa layer. It's kind of unique.
Right.
Below that, you find the main muscle layers, a circular one and a longitudinal one. They handle the movement.
Which brings us to its main job, right? Moving food down.
Precisely.
Oh.
Through peristalsis, it's that wave-like muscle contraction.
Like squeezing toothpaste.
Exactly like that, pushing food along.
And how does it control the exit down at the stomach end?
That's fascinating, actually. It doesn't have a distinct anatomical sphincter, like a tight ring of muscle.
No.
No, it's more of a functional sphincter. Your diaphragm, the big breathing muscle,
Yeah.
it wraps around the esophagus right there. That creates a sort of angle, a natural squeeze.
Ah, clever.
It really is. It helps control food passage and stop stomach stuff from coming back up.
Hmm.
Biological engineering,
And the inner lining, the mucosa you mentioned, it's not smooth.
No, it's got this irregular profile, kind of folded.
And that's important.
Absolutely essential. It lets the esophagus stretch, dilate quite a bit when you swallow, say, a big bite, so it doesn't tear.
Okay.
And this lining, it's covered by a specific type of tissue, multi-layered squamous epithelium.
Sounds tough.
It is. Think of it like protective skin inside. Its main job is protection from, mechanical injury, food scraping past.
Right.
Normally, it doesn't make keratin, that tough protein in our outer skin. And this specific lining is crucial because, well, when things go wrong, the way it gets damaged helps us figure out the disease.
Like a signature.
Exactly, like a signature left by different conditions.
Okay, so that's the esophagus working well, but what happens when inflammation strikes? Esophagitis, the autiitis suffix means inflammation.
That's the one, inflammation of the esophagus.
Yeah.
And yeah, we broadly classify it into acute, sudden onset, and chronic, which is longer term.
And what would someone feel? What are the typical symptoms?
The big ones are retrosternal pain, so pain behind the breastbone, which, importantly, can really mimic heart pain.
Oh, that sounds alarming.
It can be, yeah. And the other key symptom is dysphagia, difficulty swallowing.
And the causes, the etiologies, you said they're varied.
Very varied. Could be infectious germs, toxic, maybe drugs or waste products in the blood, uremia.
Okay.
Less common are things like ischemic, lack of blood flow, or decubitus, like from pressure, maybe a breathing tube.
But the main one?
But the big one, by far, is acid reflux from the stomach. That's the most common cause of esophagitis we see.
And it seems like the lower part of the esophagus gets the dump of it for several diseases.
That's right. That lower one-third is prime territory for reflux esophagitis, also Mallory-Weiss syndrome, that's a tear, and Barrett's esophagus too.
Why there specifically?
Mostly because it's closest to the stomach. Gets the most direct exposure to that harsh stomach acid.
Okay, makes sense. So let's dive into some specific types then. What about infectious esophagitis? You said it's rare.
Relatively rare, yeah. That tough lining usually does a good job fighting off microbes.
Uh-huh.
So when it does happen, it's often secondary. The infection spreads from nearby, like the heart sac, chest cavity, bronchi. Rarely starts in the esophagus.
And it could be bacteria, viruses, fungi.
Correct, all three.
Let's tackle the viruses first. Herpes esophagitis.
Right. Often from HSV1, the common herpes virus, reactivating in someone immunosuppressed, or sometimes HSV2 spreading.
And what does that look like?
Endoscopically, you see sudden onset, maybe some bleeding, and this characteristic cluster of blisters and ulcers, usually mid to lower esophagus.
Okay, a cluster.
But microscopically, that's where the real clues are. Pathologists look for specific things inside the cell nuclei Cowdery type A and B inclusion.
Inclusions.
Yeah, like little vital footprints. And also multinucleated cells with glassy nuclei. Very specific signs for herpes.
So those are key for diagnosis.
Absolutely. Plus, we can use fancy lab tests like IHC, ISH, PCR to confirm if needed.
Okay. How does that compare with CMV, cytomegalovirus, esophagitis, similar fingerprints?
Good question. No, quite different. CMV also pops up typically with a reactivation in immunosuppressed folks, HIV transplant patients.
Right.
But endoscopically, CMV often causes a single larger ulcer, usually down in the distal esophagus, not that cluster you see in herpes.
One big ulcer versus a cluster. Got it.
And histologically, while you do see nuclear inclusions, the crucial difference is which cells are hit.
Oh.
In CMV, it's mainly the endothelial cells lining blood vessels and stromal cells like fibroblasts, not the epithelial lining cells themselves like in herpes. That distinction tells us it's CMV.
Fascinating difference. And you mentioned a rare HIV-associated type 2.
Yeah, briefly, it's ulcerative distal esophagus, kind of a diagnosis of exclusion after ruling out other things, specific immune cells involved.
Okay. So virus is covered. What about bacteria?
Bacterial esophagitis, again, usually secondary. It complicates existing problems, maybe a tumor, an ulcer, a narrowing, or those little pouches called diverticula.
Or it jumps on after a virus.
Exactly. A superinfection after herpes or CMV isn't uncommon. Staph and strep are the usual suspects.
Main appearance.
Endoscopically, often a white yellowish coating or exudate. Microscopically, the key is the immune cells, predominantly neutrophils. That points strongly to bacteria.
Neutrophils for bacteria, lymphomonocytic for viruses, generally.
That's a good general rule, yeah.
Okay, last one in the infectious group, fungal esophagitis.
Most common cause there is Candida albicans. Thrush fungus.
Candida.
Yeah. Again, often in immunosuppressed people, premature babies, or after long antibiotic courses. Presents acutely with trouble swallowing.
And it looks?
Quite specific endoscopically. That classic cottage cheese appearance or thrush, white sort of filamentous coating over red, irritated mucosa, lots of dead debris.
Except just cheese, okay.
Histologically, you see immune cells, but the absolute key is finding the fungus itself. Pseudohyphae, those branching filaments and spores within the epithelium. Special stains help highlight them. Very visual diagnosis.
Right. Moving away from infections now. Caustic esophagitis. This sounds bad. Chemical injury.
Yes, exactly. From swallowing strong acids like HCl or strong alkalis, like NOH drain cleaner, basically. Accidental or, sadly, sometimes voluntary.
And the damage depends on?
On the substance, its pH, how much was swallowed, and critically, how long it stayed in contact with the tissue.
Contact time matters.
Hugely. And the damage is often worst at the natural narrow points of the esophagus.
Why there?
Because the substance can pool there, linger longer, and cause more intense burns. Places where the aorta or bronchi might slightly compress it.
Makes sense. And under the microscope.
You can see massive swelling within the cell's spongiosis, widespread tissue death, necrosis, and again, lots of neutrophils in the inflammatory response.
Any long-term problems from this?
Oh, yes. A very serious one is acquired stenosis. Scar tissue forms from the chronic inflammation, leading to a permanent narrowing in the esophagus.
Nasty. Okay, next, iatrogenic esophagitis. Iatrogenic means caused by treatment, right?
Correct. Caused by medical intervention. In this case, certain drugs getting stuck or irritating the esophagus.
Like which ones?
Common culprits are things like iron sulfate pills, NSAIDs, ibuprofen, and like doxycycline, quinidine, and a bone drug, alendronate.
So knowing the patient's meds is key.
Absolutely crucial for diagnosis here. Clinical history is paramount.
Okay. Now, eosinophilic esophagitis. You said this one's becoming more common.
Yes, definitely seeing more of it. More common than viral now, actually. Affects adolescents, young adults, really all ages.
And it's not an infection.
No, absolutely not infectious. It's a chronic immune-mediated disease. Think of it like an allergic reaction happening in the esophagus.
An allergy in the esophagus. Wow. Symptoms.
Related to esophageal dysfunction. Difficulty swallowing is common. But a very specific symptom, especially in adults, is food bolus impaction.
Food gets stuck.
Literally stuck.
Yeah.
Especially dense, protein-rich food that isn't very moist.
And looking inside, any specific signs?
Yes, endoscopically, a very classic sign is concentric mucosal rings. We call it trachealization because it makes the inside of the esophagus look ribbed like a windpipe.
Trachealization.
Yep.
And the eosinophilic part.
That's the key histologically. Eosinophils are a type of white blood cell, often involved in allergic reactions. Here, you see loads of them in the biopsy.
How many is loads?
The diagnostic criterion is usually at least 20 eosinophils per high power field. That's the view under the microscope. That high number really distinguishes it from other types of esophagitis where you might see a few stray eosinophils.
So the count is critical.
Very critical for diagnosis.
Right. Let's pivot to the big one we mentioned, reflux esophagitis, the most common type. You said many people don't even have symptoms.
That's right. Many cases are asymptomatic. Others might just have some indigestion, dyspepsia, or belching. And it typically hits that lower third near the stomach.
What does it look like inside?
Often just diffuse redness, maybe some red streaks, striae rubrae. But chronic damage can cause more severe issues, even vomiting.
And vomiting from other causes can trigger reflux too.
Yes, absolutely. Neurological issues causing vomiting can lead to chronic reflux damage.
What makes someone prone to reflux?
Several things. An incompetent cardia is that junction with the stomach isn't closing properly. The reflux of acid and pepsin, obviously. Sometimes bile reflux, maybe not enough protective mucus.
And lifestyle factors?
Oh, yes. Transient relaxation of that lower sphincter muscle, stomach being too full, distended. Increased pressure in the abdomen, think obesity, pregnancy, alcohol, tobacco use. And a big one, hiatal hernia.
Hiatal hernia where the stomach pushes up.
Exactly. Pushes up through the diaphragm. Very common contributor.
Okay, quite a list. So, microscopically, what story does a biopsy tell in reflux?
We look for a few signs. Engorged blood vessels in the lamina propria, that's vascular congestion. More specifically, hyperplasia of the basal epithelium.
The bottom layer gets thicker.
Right. That regenerative layer goes into overdrive because the surface is being damaged, leads to this sort of wavy, papillary look, epithelial papillomatosis. Other signs. Spongiosis, that's cell swelling. Increased inflammatory cells, maybe a few eosinophils, but not like NeoE, balloon cells, and eventually erosions or ulcers.
And those erosions can lead to worse things.
They can, yes. They can set the stage for conditions like Barrett's esophagus. Diagnosis really needs the combination: scope findings, biopsy, and the clinical picture.
Which brings us neatly to Barrett's esophagus, a major complication of chronic reflux, you said. What is it exactly?
Barrett's is a metaplasia, a transformation. The normal squamous cells lining the esophagus change type.
Change into what?
Into columnar cells, the kind you normally find in the stomach or intestine.
Why would they do that?
The leading theory is it's an adaptation. Constant acid damage triggers the underlying basal cells to differentiate differently into a cell type perhaps more resistant to acid.
An adaptation, but is it a good one?
Not really. While it might handle acid better, this new columnar lining is less protective against mechanical injury. And crucially, it carries a significant risk.
How does it look on endoscopy?
Visually, it's quite striking. The Z line, that normal junction between the pale esophagus and pink stomach lining, gets irregular, jagged. And you might see these tongues or patches of salmon pink mucosa extending up into the esophagus.
Salmon pink. Why that color?
Because the normal squamous lining is thick and whitish, hiding the blood vessels. This new columnar lining is thinner, so you see the blood vessels underneath, giving it that pinkish color.
Okay. And how common is this?
Estimates vary, but maybe around 10% of people with symptomatic G or D might develop Barrett's. More common in men, typically diagnosed in middle age, 40s to 60s. It takes time to develop.
Right, chronic damage.
Exactly. But the absolute most critical thing about Barrett's is the significantly increased risk of esophageal cancer, adenocarcinoma specifically.
That's the main worry.
That's the main worry. It makes regular endoscopic surveillance absolutely essential for these patients. It's a silent change that really increases cancer risk.
Under the microscope, besides the metaplasia itself, what else confirms it?
Well, seeing intestinal metaplasia is key. That means finding specific cells, like goblet cells or Paneth cells, which are normally in the intestine.
Goblet cells, the mucus ones?
Yes. Finding those makes the Barrett's diagnosis easier and is strongly linked to that higher cancer risk.
So once Barrett's is found, what's the next level of concern? What signals cancer might be developing?
The critical sign is epithelial dysplasia. Dysplasia basically means abnormal cell growth, a precancerous change.
Low grade versus high grade.
Exactly. Low grade means a lower risk, but still a risk. High-grade dysplasia, however, is highly suggestive that cancer is either present nearby or imminent. It requires immediate attention.
And this develops over time.
Yes. Tends to progress with age, peaking maybe 70s, 80s, due to that ongoing chronic damage.
What does dysplasia look like microscopically?
Cells might produce less mucus, making glands look darker. The nuclei get bigger, darker, more oval-shaped, irregular, and typically you don't see much inflammation right around the dysplastic area itself.
And high grade means?
High grade means very high likelihood of cancer. Needs aggressive management. We can also use p53 mutation testing with immunohistochemistry.
P53, the tumor suppressor gene.
That's the one. Testing for mutations can help confirm dysplasia if the visual changes are a bit borderline, and a Barrett's diagnosis really mandates that ongoing surveillance yearly or even twice-yearly scopes. Serious implications.
Okay, a very serious topic. Let's transition now to tumors of the esophagus more broadly. You mentioned malignant ones are more common than benign here.
Sadly, yes. Malignant tumors predominate, and the prognosis is often grim. Discovery is frequently very late.
Why so late?
Symptoms often don't appear until the tumor is quite advanced. Plus, it can metastasize, spread relatively early. So survival rates, even for cases they can operate on, are often low. Less than 30% at 5 years isn't uncommon.
That's sobering. What about the benign, non-cancerous ones? Are there any common ones?
Yes, the leiomyoma is the most common benign tumor. It grows from the smooth muscle cells in the esophageal wall.
Leiomyoma, smooth muscle.
Right. Often causes no symptoms until it gets pretty big, maybe 3 to 4 centimeters. Then it might cause dysphagia or bleeding, usually a smooth lump inside the wall.
Anything distinctive about it?
Yes. Crucially, it's the only esophageal tumor that commonly calcifies. So seeing coarse calcifications on imaging strongly suggests leiomyoma, usually single, sometimes multiple.
And other benign ones are rare.
Much rarer. Things like fibrovascular polyps, papillomas, lipomas, neurofibromas, granular cell tumors, often just incidental findings.
Okay. Let's focus on the malignant ones then, esophageal carcinoma. You mentioned an interesting geographical pattern.
Yes, very striking. High-risk zones include parts of China, Mongolia, Japan, India, South Africa, Iran, also pockets in Europe, Ireland, UK, France.
Why such differences?
Likely linked to dietary habits, nutritional factors, maybe environmental exposures in those regions. It's an area of ongoing research.
And where in the esophagus do they usually occur?
About half occur right at the bottom, the cardius, or in the lower third. It's much rarer higher up in the esophagus.
And the types. You mentioned two main ones earlier in relation to risk factors.
Exactly. Two main histological types. First, squamous cell carcinoma, or SCC.
Squamous, from that lining we talked about.
Precisely. Originates from the native squamous epithelium. Tends to affect the upper 2/3, especially the middle section.
Risk factors.
Strongly linked to smoking and alcohol. Also, previous head and neck SCC, lie strictures, achalasia, that motility disorder causing food stasis HEV infection, certain syndromes like Plummer-Vinson or tylosis, celiac disease, radiation.
Okay, so SCC is often upper middle linked to smoking, alcohol, and other irritants. What's the second type?
Adenocarcinoma. This one arises from gland cells, often within Barrett's esophagus.
Ah, the Barrett's connection.
Yes, so it predominantly affects the lower 1/3 and is strongly associated with GERD in Barrett's. It's a more common type in the lower esophagus in many Western countries now.
So lower third linked to reflux and Barrett's, that's adenocarcinoma.
Correct. A clear distinction in location and primary risk factors.
And the biggest challenge remains late symptoms.
Unfortunately, yes. Symptoms are often late and very nonspecific. Trouble swallowing, pain, nausea, vomiting, weight loss.
Cough or hoarseness, too.
Yes, if the tumor presses on nearby nerves. And in very advanced disease, you might find a swollen lymph node above the collarbone Virchow's node, a sign of metastasis.
Why is the prognosis often poor?
A key reason is the esophagus has a really rich network of lymphatic vessels. This allows cancer cells to spread quickly and easily to lymph nodes and then beyond. Makes early containment difficult.
To stage the cancer, doctors use the T&M system, right?
Yes, T&M classification. It's the standard language for describing how advanced a cancer is. Helps predict behavior and guide treatment.
Can you quickly break down T, N, and M for us?
Sure. T is for tumor. Describes how far the primary tumor has invaded. Tis is very early, just surface. T1 invades the inner layers, potentially curable. T4 means it's grown into adjacent structures. Big range.
Okay, T is tumor invasion depth then.
N is for nodes. Regional lymph nodes, the nearby glands. N0 means no lymph nodes involved nearby. N1 means they are. If nodes farther away are involved, that counts as metastasis.
Got it. And M?
M is for metastasis. Has the cancer spread to distant organs? M0, no distant spread. M1, yes, there is distant metastasis.
So TNM gives a snapshot of the extent.
Exactly. A higher stage generally means a worse prognosis. Treatment, unfortunately, often has to be very aggressive major surgery to remove the esophagus.
Which impacts quality of life.
Significantly. It can extend survival, sometimes by years, but it's a life-altering operation.
So as we wrap up this deep dive, we've really journeyed from the basic anatomy, this often ignored tube, through various ways it gets inflamed, like esophagitis.
All the different types.
And finally to the really serious issues like Barrett's and esophageal cancer.
And it really does underscore how important it is to understand these connections. Some seemingly common, like reflux.
Yeah, heartburn.
Can genuinely, over time, lead to these precancerous changes like Barrett's. It highlights the need to pay attention to symptoms and the power of, well, early diagnosis if things persist.
Which kind of leaves us with a final thought, doesn't it? Given how silent some of these conditions can be, like early Barrett's or even early cancer, and the difficulties with late diagnosis, what does this tell us about our bodies? About their hidden resilience, maybe, but also their vulnerability.
That's a profound point. There's incredible resilience, but also these pathways where chronic irritation can lead down a dangerous road.
So what does this all mean? I guess it means staying aware, staying informed is really key to looking after ourselves. Thanks for joining us for this deep dive.